Good evening, everyone. Thanks for joining us on another TOTEM talk. Tonight we have a talk from Professor Justiaan Swanevelder, also goes by Justiaan or Swanee. He's a very experienced cardiac anaesthetist or cardiothoracic anaesthetist in both adults and pediatrics, currently working in Leicester, and brings a wealth of experience from both South Africa and the UK in the field of echo. He's published lots of publications in this field and has been on the board for a number of different echo accreditations, or at least been a big contributor to a lot of echo accreditations over time. He's a very experienced and humble guy and a great teacher. So we're really looking forward to a talk with you tonight.
Thank you, and Samson, it is really a privilege to be part of this nice program of yours. I would ask you to stop me anytime if there's interruption or a question for questions. Yes, definitely, but also for if there's any form of interruption with a presentation or the footage on the screen and so on. I met Samson the first time at Red Cross Children's Hospital not so long ago when you were doing your stint there. It was really nice. We stayed in contact, and I'm back in the UK now, in Leicester, which is right in the middle of the country. It's very famous for Richard III and lots of other historic things that took place and happened here. And it's really a privilege for me to come back to Glenfield Hospital and the Leicester Royal Infirmary, where I do adult and pediatric congenital cardiothoracic mainly. I have to give credit and pay my respects to Cape Town, where I originally come from. I worked there for a long time, and I've been from 2012 to 2024, I've been at the Groote Schuur Hospital and Red Cross Children's Hospital, the University of Cape Town. And so really a lot of good work is being done there. And like in the rest of South Africa, where there are pockets of severely high-end expertise, and I'm just thinking Bloemfontein, who I know is represented here, and people are doing very excellent work and always enthusiastic to learn. So Samson asked me to talk on the aorta and aortic syndrome, so I'm going to do a little introduction about the anatomy, then a few things about the diagnostic modalities, pathology of the aorta, and specifically the acute pathologies like dissections and intramural hematomas. And then we will look at examples of emergency cases, but also intraoperative procedures that took place. And I'll mix it in between. I'll make use of examples. The aorta as an organ, and lots of guidelines by sort of very respected bodies from around the world, both sides of the Atlantic, in the States and in Europe, and people are continuously bringing out new guidelines on acute and chronic syndromes. There are just two of them, and the diagnosis and management of the aorta. If you're interested in this, everything is taken up in that, and you can find all the detail of what I'm going to say in those. Just to know that the aorta is not, everyone's aorta is not exactly the same. You can get a big variation of how the head vessels are coming off. The aortic arch may be different, and there is a standard of the brachiocephalic artery, and then the left internal carotid or common carotid, and then the left subclavian. And you do get a variation. I'm not going to spend too much time on this, but that can affect how a surgeon will approach the surgery. Also, Ishimaru has not so long ago come up with his zone 0, zone 1 and 2, and zone 3 and 4. And 0 is the ascending aorta. Remember that the only arteries or vessels coming off the ascending aorta are the coronary arteries. There are no other vessels coming off unless it's an abnormal ascending aorta. Then the head vessels are coming off zone 1, 2, and 3. And we've mentioned them, and that is usually fairly routine where they're coming off. And then I think it's important for us as not only anaesthetists, but also echosonographers to know that what's coming off the descending aorta, first of all, the celiac plexus, which has got the hepatic, the left gastric artery, the hepatic artery, and the splenic artery coming off. And then after that, we find vessels like Adamkiewicz, which the anterior spinal arteries, and also the superior mesenteric, inferior mesenteric, and in between comes off the renal arteries. Important to understand which vessels supply which organs, and even the gut where it is supplied from. So we know about the different layers of the aorta, the intima, media, and adventitia. And whenever we've got pathology, like for instance a dissection, it's usually when there's blood splitting up the level, the intima and the media. And just with different pathologies, different parts of this will be abnormal. We're going to start with an example. And when we have an aortic aneurysm, it can often be accompanied by aortic regurgitation. This specific patient is a Marfan's patient with a hugely dilated aortic root. Remember that the root is from the level of the annulus, which is not a round ring, it's like crown shape, the sinuses of Valsalva, and the sinotubular junction. That will make up the root, and the leaflets are included in that, the aortic valve leaflets. And then the sinotubular junction to the ascending aorta in this specific patient is hugely dilated, like you would expect with a Marfan's patient. Now, it's when you have aortic regurgitation in these patients, it's usually pathology of either the aortic valve or the aortic root and cusps, or both of that. And different pathologies will give you different symptoms. And in this specific patient has got severe central jet of aortic regurgitation due to a dilated aortic root. And this is torrential, severe AR, and something needs to be done. In this specific patient, one also appreciate the fluid around the ascending aorta. There is not a dissection yet, but it will happen very soon if it hasn't happened yet. So this is a weakness in the wall of the aorta, and a surgeon will address it. Now, usually when there's a functional classification, and I'm not going to say too much about the aortic valve, but just a little bit, because this is part of our discussion of the aorta. So if there's a type 1, type 2, or type 3 regurgitation, and it's very similar, Dr. El-Khoury, who I had the privilege of meeting and talking at a dinner, and he explained very nicely to me on the back of a serviette with a pencil, and I'm sorry I didn't keep it because I would love to include it into this slide. He's from Saint-Luc Hospital in Brussels, and really one of the pioneers and pushing the whole classification of aortic regurgitation, same way as Dr. Carpentier classified a mitral regurgitation. He says type 1 is when there's normal cusp motion, type 2 is when there is a cusp prolapse with an eccentric jet, and type 3 is usually when there's a restricted cusp motion, and the jet will go in the direction of the retraction or the thickening. Now, this is an example of AR due to type 1A. It's a 75-year-old male with ischemic heart disease. But by the way, the patient came for coronary grafts, but they say also for moderate aortic valve. So in this case, the vena contracta, the narrowest neck of this regurgitant jet, is 0.5 centimeters. So it certainly is on the high end of moderate to severe. And this patient's coming for his coronary grafts. Now the valve needs addressing. Now, this was about 10, 15 years ago. Remember that nowadays there are newer options, and the newer options like percutaneous aortic valve implantation is sort of more readily available for more of these. And this would need to be discussed in a multidisciplinary team and discussed what would be the best option for this patient. But in this case, we did surgical repair of this aortic regurgitation, but also the coronary grafts. So just to make a measurement, we measure the annulus. In this case, it's almost 23 millimeters. The sinuses of Valsalva, 32 millimeters, sinotubular junction, 29 millimeters, and then the ascending aorta, 5.3 centimeters. So 53 millimeters. Now that means it exceeds the limit, the top end, and this ascending aorta needs addressing. So it's huge. There's 6.4 centimeters, 64 millimeters, and this aorta is so weak. Remember that if you think of Laplace and the whole wall tension of Laplace, this aorta is making, when you make use of the Laplace law, wall tension equals pressure times radius over thickness, and that means this is very high wall tension and a thin thickness. So this thing can pop any moment. The surgeon then did remodeling of the ascending aorta by wrapping it with Dacron graft. He didn't address the aortic valve at all, just by bringing the sinuses of Valsalva and everything together. This valve leaflets, the splaying of the leaflets were stopped, and it has now got good coaptation, and we don't have to do anything else. The patient had coronary grafts and this wrapping, and this is a very well recognized technique that surgeons have been doing for a while, without, especially if it's an elderly patient and you don't want to replace the whole ascending aorta in a patient of 75, 80 years old. It brings huge morbidity to a patient like that. So you want to limit the risk and the morbidity for those patients, and in this case, this is an option. So aortic valve procedures, the definitions are, they say aortic valve sparing or aortic valve salvage in an emergency case, or aortic valve repair. And there are different terminologies that surgeons use, and when we do ultrasound intraoperatively or perioperatively, one of the important things is to learn this new language. When we use ultrasound, we use cardiology and cardiac surgical language, and especially in the operating theater. It is important that you ask your surgeon. I've learned more from surgeons than I've learned from echo people or cardiologists teaching you echo. So it's important to discuss with the surgeon. What do you call this? What procedure are you going to use? What are the measurements? What do you make of these measurements? Surgeons can think in 3D, 3 dimensions. And that's actually what we're doing with ultrasound. We have a 2-dimensional picture, nowadays also 3D, but a 2-dimensional picture. And in our head, we build a 3D view, a 3D picture, and then we can see this 3-dimensional structure from all different sides. So valve sparing, valve salvage, and valve repair. So we always ask, what does King George II and Michael DeBakey, we all know about DeBakey, and what do they all have in common? And it's acute chest pain. And this was in 2006. Michael DeBakey was something like 94 years old. He owned the hospital, and he devised the operation, and he developed it, and he then suddenly had chest pain. And by the way, King George had it while he was stressing on the commode, but he didn't have a surgeon or a hospital to look after him, and he just passed away on his commode. Well, actually, Michael DeBakey was lucky. He got an operation. It did take 3 months to find an anaesthetist who wanted to, had the balls to anesthetize him, because he was a difficult guy and he owned the hospital. Nobody wanted him to die on them when he's 94 and he's getting this big operation. So it was a bit of a complicated political and decision making, but he ended up getting through his operation. He kept his office in the hospital, and I think he was alive for another 3-4 years, probably not operating too much, but in and out of his office. This is a 72-year-old patient, uncontrolled hypertension with acute back pain. And I would ask Pete, but unfortunately he's not in front of me. Otherwise I would ask him, and I'm sure he would tell you that we've got a short axis, mid-esophageal short axis view. I don't know whether my mouse is visible, but I'm using the mouse on my computer. But we've got a short axis view of the aortic valve with the 3 cusps, a left coronary cusp there, a right coronary cusp anterior at the bottom of your screen, and a non-coronary cusp adjacent to your interatrial septum. Seems like good color. Can you see them? Can you see my mouse? Okay.
Yes.
That is good. So that what I'm pointing at now is the right coronary artery coming off there. Now remember, the surgeon is operating from this side, from the bottom of the screen. By convention, this is what we will see in the operating theater. The left atrium is closest to your esophagus, is right there in the apex, in the, of your triangle, and then we're screening this way. So that's the left atrium, ascending aorta coming straight at the audience, and the intraatrial septum there. So if we look at where the right coronary artery is coming off, there's something not normal there. And immediately when you see this, you must think, is that an intimal flap or what? And if you then withdraw your transducer a little bit, you go a higher mid-esophageal, higher esophageal, then we appreciate this ascending aorta at 7 centimeters in. So it is not that hugely dilated. It's about 3-4. We're scanning at 7 centimeters from there to the, the full spectrum that we see. And then we appreciate the intimal flap. Now, the question is always, which is the true lumen and which is the false lumen? And the false lumen is usually the smaller one that expands during systole, 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 systole. There's no turbulence there. The true lumen is the bigger one, and that is. Now, the next important thing will be to find the intimal tear. I've taken that previous picture and just turned it to 90 degrees, turned a bit to the left, and this is my descending aorta with the head of the patient on the right side of the screen by convention, and the feet of the patient on the left side of the screen, and the blood flowing from right to left as you look at the image. We've got color flow Doppler. Remember that color flow Doppler makes use of the pulse wave Doppler principle, and red towards the transducer and blue away from the transducer. The true lumen is at the top and the false lumen at the bottom. And there is laminar flow on both sides. So obviously there is somewhere is an intimal tear. Now, dissection, when we talk about it, usually the most common causes for that is patients with hypertension, long-standing uncontrolled hypertension, patients with Marfan's syndrome, and these are the high-risk patients. There's a low threshold to operate on them and replace the ascending aorta because they've got lots of things wrong in the heart. It can be a mitral valve prolapse with degenerative mitral valve prolapse, but also the ascending aorta with aortic valve leaking, aortic regurgitation. And then the bicuspid aortic valve. Again, this is a congenital situation. Marfan's is more of a genetic, but bicuspid is a congenital, truly congenital heart disease where there is also weakness in the intima, the media. And often the blood then comes in between the media and the intima, and they say it is more common in the female gender. Obviously, when you're smoking and COPD and you're coughing, it is more common. 50 to 70 years of age, period mortality still extremely high on a national level here in the UK, and especially if it's not diagnosed. They say there's 1% mortality for the first per hour for the first 48 hours. You can understand that if you've got aortic dissection, the sooner you get to a big center where they can operate on you, the better. And this is a aortic emergency. And this is what I mentioned earlier on Laplace law. Basically, wall tension equals pressure times radius over 2 times the wall thickness. And it is a rupture risk when the radius is more than 5.5 centimeters. Or, yeah, actually the diameter is more than 5.5. So when the wall tension is too high, then it exceeds its bursting strength, and this aorta will pop. Now, usually what happens, there's an intimal tear that forms, there's a false lumen, the bigger one, and a true lumen, and the blood comes into a true lumen is where it originally the blood flows, but it then becomes a false and a true lumen. And the commonest site is just above the aortic valve, and that's also the most dangerous cases. The aortic usually can be distal to the often distal to the left subclavian artery, and the problem is when there is occlusion of the aortic branches. So you will say, if a patient loses his left radial pulse, or a patient loses consciousness, or there's a hemodynamic instability, or there's, which will go with a tamponade, or any of those, a patient loses consciousness or alertness, then you will be sure that one of the head vessels are involved, and this is a big problem. Now, as the guidelines say, we know about Stanford A, B, and non-A, non-B, and Stanford A is the one which will need urgent surgical intervention. Stanford B, they can treat in the cath lab or in the interventional radiology lab, where they are nowadays with TVARs and EVARs and all of those. There are many variations, and the interventional radiologist and the cardiologist, interventional cardiologist, and the surgeons all make part of the heart team and work closely together. And of course, anesthesia is a big player in this, because for us, it is to keep this patient stable until this section is treated. Now, this can be the same used for either a dissection or even aneurysms have got this type of classification, and there's a little bit of a mixing between aneurysmal and dissection nomenclature. So we talked about also the duration is important. Is it acute or is it chronic? It's acute when it's less than 2 weeks after the onset of the first symptom. It's chronic when it's more than 2 weeks. And we talk about a dissection or a penetrating ulcer. Even I've seen recently in South Africa, patients coming back with syphilis of the ascending aorta and ulcers and ascending aortic aneurysms and dissection due to that old-fashioned syphilis, which we would not have thought still exists, but it's in the textbook, and it's also still to be found in the patients, often in low and middle income countries. Intramural hematomas is the same acuteness, the same severity and urgency as you would get with an aortic dissection, the same need to move quickly, and an intramural hematoma, as we said. I'm not going to spend too much time on endovascular repairs or abdominal aortic aneurysms, but there are many different providers of these prostheses. Usually it's interventional radiology lab with fluoroscopy, contrast, angiography, and also echo screening. And for us, it is to see whether there's sort of residual endo leaks, as they say. And often these things are done under local or under sedation, but often when the patient is unstable, the anaesthetist will be heavily involved. The one on the right there, like this hybrid type of procedure, often more and more are commonplace, where the ascending aorta and the arch is done by a surgeon, and then this elephant trunk dropped into the descending aorta, the head vessels reimplanted. This is a huge procedure and undertaking with a lot of morbidity and risk, and that's a whole story. If one day we have time, I'm happy to talk about elephant trunks and arch procedures. That's a bit more specific. Now, what about imaging? Angiogram was historically the old way of doing it. X-rays, when we see an X-ray like this with a broad mediastinum, yes, of course, it rings an alarm bell. CT, then more and more now, and MRIs. And there, about 15, 20 years ago, there was a big argument, discussion about what is now the most important. Should all patients get a TOE? Should all patients go to CT or MRI first? And as CTs and MRIs became more readily available, it very much depends, and also TOEs, intra-op and peri-op. And the whole thing is not to delay a procedure where there's a high diagnostic chance of a dissection. And we would easily bring a patient in which comes in from outside with this diagnosis into the operating theater without often a CT or an MRI, and you do a TOE because it's already diagnosed somewhere else. On the other hand, if your hospital has got more expertise in CT and MRI, the patient comes in and goes back and they discover it and diagnose it there, then so be it. CT and MRI is important. So the diagnostic value of these different modalities are more or less the same, and is important that the diagnosis is made quickly. Transthoracic imaging, just a few words on that. Parasternal long axis, apical two-chamber. Suprasternal is what we have here, with the arch and different types of transducers. But the idea is you put it in the suprasternal notch, you scan onto the aortic arch, and then see where the ascending aorta, the arch, and the descending aorta is visible. Now, remember with TOE, and I'll say a few words on why not, but the arch is not clearly visible with transesophageal echo. Why is TOE so important? It's because it's quick, it's at the bedside, it's continuous throughout the procedure. In unstable patients, it's invaluable because it gives you additional information which may change from beat to beat, or which may change from minute or hour to hour. Perioperative, in not only as a diagnostic tool, but also as a very good monitor in unstable patients. High quality imaging, real-time analysis, and it tells you about the functional status of the patient. Now, just we're going to make use of all of these views. I'm not going to teach you about normal transesophageal echo, but the upper esophageal views, the upper esophageal view in the long axis of the ascending aorta, of the descending aorta, the short axis view of the descending aorta, and then also further up where one can see the pulmonary, or the right pulmonary artery coming straight at the audience with the ascending aorta. Now, why is the arch not visible? And this is a question I always ask the medical students, and for that matter, also the anaesthetist younger anaesthetist in the theater, is what happens at the level of T4? And if you think back to your second year medical student time, the anatomy lectures of T4, the angle of Louis, there are 12 different things happening there. And I'm not going to give you a lecture on that because there's not time. But the most important is that there's a bifurcation of the trachea into the left and the right main bronchi. And then there's also the aortic arch coming at the level of T4 and several other things. But the trachea is between, and the bifurcation of the trachea comes between the esophagus and the arch. So you very poor visibility and view of the arch. There are now new techniques like the A view. Arno Nierich from the Netherlands, Zwolle in the Netherlands, he's a good friend. He visited South Africa several times, and he has designed this sort of A view, this balloon you can put into the trachea, inflate it, and then it gives you a good view of the arch. Otherwise, transthoracic is easier to see the arch, but usually if the ascending aorta is clear, then it is important to exclude that the head vessels are not involved into any form of dissection. We've mentioned the level of the angle of Louis, the T4, and I'm not going to say too much more. Transthoracic and epicardial scanning, they were hugely published. Steve Stanton Shernan published on epicardial and epiaortic scanning and the standoff you use and the type of transducer. And then just to keep it sterile, the surgeon can put the transducer onto the arch and exclude atheroma so that you don't cross-clamp a sort of porcelain aorta and atheroma in the aorta. And it is okay. So let's move on to a few examples. We are sort of almost running out of time, and I've got a lot to still show you. 63-year-old patient, acute aortic dissection, proximal origin, and the valve is certainly involved. The question is, is there coronary involvement? Now, this is explain. Using the explain modality in the more modern echo machines or vendors will show you this, where there's an orthogonal plane onto your short axis view. So the short axis view and the long axis view, and it shows you simultaneously how this commissure between the right coronary cusp and the non-coronary cusp is dehisced from the ascending, from the root. Okay, So there is a dehiscence, and it's very clear in the long axis view too, how the intimal flap comes down, and you would want to know, is this right coronary artery involved in that? Because the right coronary artery comes off anterior, is the most anterior coronary artery. It seems like the left coronary artery and the left coronary cusp and the right coronary cusp, the commissure is functional and working, and the valve is operating all right. Well, this commissure is totally dehisced. Intimal flap is coming right down into the root and may very well involve the coronary, the right coronary artery. With 3D, it shows us not only lines, but it shows us nice surfaces, and we can appreciate the valve itself a little bit more better. With 3D, you can turn this image around and look where the coronary artery comes off, and make sure that you exclude any involvement of your right coronary artery. Now, this patient, what shall we look for when we have a patient with a dissection? First of all, the hemodynamics. Point number one. This is the descending aorta of that same patient, with the intimal flap going right down into the descending aorta. So it means it is a type A dissection, including the ascending, the arch, and the descending. So this needs surgical intervention. This patient may be hemodynamically unstable or not. So you confirm the diagnosis. It's important to help the surgeon with, and especially remember that an aortic dissection can evolve. It can progress from half an hour to half an hour. It can get bigger. And we know that the mortality rate goes up 1% per hour. And therefore, within the first 48 hours. So therefore, what is a dissection now will not necessarily look the same. What you have diagnosed with CT or MRI may be much worse 2-3 hours later when you get to a center where they can operate on this patient and the patient's on the operating table. So the surgeon wants to know, where is the entry site? Where is the true lumen and the false lumen? What is the volume status and the hemodynamics of this patient? Is there a tamponade, yes or no? Is there a pleural effusion? Yes or no, because that'll affect your ventilation and your cardiopulmonary interaction. Is there a pericardial effusion or tamponade? Is the aortic valve involved? Now, if any of the coronary arteries are involved, then there may be regional wall motion abnormalities. And you see that by looking at the short axis view of the left ventricle and excluding wall motion abnormalities. Very easy to see if there is hypokinesia or akinesia or dyskinesia, which will be the worst one when there's involvement of the coronary arteries. The function, is it good contractility? Remember, a patient with hypertension usually is good function unless the coronary arteries have had an incident. Then you can guide cannulation, and then, of course, afterwards, the integrity of the surgical repair. This is one of the most common procedures still around the world. Now, to keep in mind that Bentanel and De Bono, Dr. De Bono was a cardiologist here in our hospital. They even called the library the De Bono Library. And I had the privilege of meeting him long ago. He's passed away now. But and him and Dr. Bentanel came up with, and I think they did 5 cases and described this mechanical prosthesis. So a mechanical valve, bileaflet valve usually, with an ascending tube graft connected to it. And this would be then justify, they would do a reimplantation of the coronary arteries. And this is up till this day called a Bentanel procedure. The valve is replaced. We appreciate the mechanical shadowing. You don't see very much distal to this metal in the where the aortic valve is. This mechanical prosthesis, and then the ascending aorta. And this is, even today, is a very common procedure for aortic aneurysm or aortic dissection, or when the surgeon wants to get in and out. And the reimplantation of the coronary arteries may be the tricky bit and the important bit. This is a 60-year-old year. All patients seem to be 60 years old in our hospital, but this acute dissection also come in 63 years old. And this patient had a dissection, intimal flap going right down to another example to the right coronary artery. Now, it is clear to see that this ascending aorta is dilated. So immediately I would say this is also a patient very likely to be Marfan's, and you would immediately look at the fingers, look at the mitral valve. This one has not got prolapse, but is the patient a tall patient? Has he got any other signs or symptoms of Marfan's? But this is now an intimal flap going right down to the aortic valve. Again, the dehiscence, I've showed it previously. Now, how would the surgeon act? And then it depends on how adventurous your surgeon is, how keen they are to repair. And you would find that this is usually not every surgeon likes to replace or do a David procedure. Now, a David procedure is this, the root replacement with aortic valve reimplantation. And Dr. Tyrone David, many people who have worked in Toronto had the privilege of working with him. Many of our friends tell stories about him. And he designed this, and it's a David 1 and a David 2. And basically, they put a new tube graft on, resuspend the commissures and the leaflets onto the annulus, originally cut it out and do this type of procedure. Too technical to go into. This is a surgical discussion. Professor Magdi Yacoub, then at the same time, more or less, one of the icons from Airfield Hospital and the Brompton, and he described his technique because surgeons have their own techniques of repairing it. And these people were really pioneers in the repair of and preservation of the aortic valve. That's where there's an aneurysm or the ascending aorta needs repair or replacement. And but basically, again, it is easier. The sinus function is preserved, and it's a remodeling of the root. Okay, so there's an example then of the new BioValsalva composite graft and valve, where there is a tissue. Now, some of the companies come out with a tissue, a piggy valve on a stent instead of a mechanical valve. You may have an older patient who does not want or will not go well with warfarin. In other words, this specific patient needs a tissue valve, and now they've got a prosthesis like that, where the sinuses are preserved. And I've seen these valves being put in and the reimplantation of the coronary arteries. And now you've got the sinuses of Valsalva preserved. So it gives you that diastolic pressure buildup, which drives the blood flow into the coronary arteries to give you good coronary blood flow and preserve the coronary supply of the myocardium. Now, there it is. It's a tissue valve, a piggy valve, in this newly preserved aortic root, if you may. And with 3D, it just demonstrates a nice image with the left atrium at the top 30, and your eye gets used to the 3D technique. I'm not going to say too much about this valve. I'm going to move on to the next image. My computer is just thinking at the moment, and it will appear very shortly. This patient was 58 years old and a patient with Marfan's, and I want you to pay specific attention to this intimal flap. It basically goes through the aortic valve, although it keeps the right coronary cusp in the open position. Remember, by the way, a Marfan's patient, and it took me a while to find this out, but if you talk to the geneticists, or Marfan's patients don't have bicuspid aortic valves. The same as a bicuspid valve, patient with a bicuspid valve may have an ascending aorta that's dilated, but a bicuspid valve does not go with a Marfan's patient. So it's two different entities. One is congenital and the other one, both of them, of course, genetic, and it's in the genes. But these are two totally different syndromes. And there's the ascending aorta, very much dilated. And if you know, look at this intimal flap, which goes and almost prolapses into the, there's the short axis. True lumen in this case will be that one where the flow is, and the false lumen where there's the spontaneous contrast, hugely dilated ascending aorta. We appreciate that there's a fluid around the aorta, fluid right around in the transverse sinus behind the aorta. So if a patient's lying on their back, so you have to ask yourself, is there blood already seeping through that aortic valve. This patient is going to have a rupture of this aortic aneurysm very, very shortly. This is a crucial problem because there's already blood outside of the aorta. And this patient needs surgical. There is no way you can do anything else now. Now I want you to compare the next. Let's just see. Okay, that's the descending aorta and the true lumen at the top and the false lumen at the bottom. This is what they've done in this specific patient, the ascending aorta replaced. And I want you to look at these two images, two different patients. The one at the top is different from the one at the bottom. The patient at the top has got an intimal flap that has got an intimal tear that is prolapsing through the valve. So there is torrential aortic regurgitation during diastole, which leads to that left ventricle being overdilated, volume overloaded. We appreciate that the mitral valve doesn't, this is the image on the left, the mitral valve almost doesn't open at all. So the forward flow for this patient is very, very slow. And there is a dilated left ventricle which is not functioning very well. The image on the right, they've got a dilated ascending aorta, but the intimal flap acts almost as a valve. Left ventricle looks happy, the patient's not in trouble, mitral valve opens nicely during diastole, and this patient has a totally different scenario to the one on the left. The patient on the right has got a preserved left ventricle. And again, if we look at the following images, just pardon my slow response, the one on the left is the patient where the volume overloading of the left ventricle is very visible, while the patient on the right, the transgastric short axis view of the left ventricle, nice and a happy ventricle. It has not experienced the ventricle is not affected by the dissection. The one on the left, definitely the ventricle is affected by the dissection. So two different scenarios. Intramural hematoma, similar type of urgency, and we appreciate the ascending aorta short axis. There's a thickening and clear to see, and this is, you treat it as a dissection. That just now you have got blood between the intima and the media, and it may have thromboclotted off. The 90 degrees to that, at 140 degrees view, we see the ascending aorta with a valve there, and the ascending aorta with the double layers of that ascending aorta. So certainly a patient in trouble. That previous patient, there is the descending aorta of that patient, and the intramural hematoma has gone right down into the descending aorta, thickened wall, and this patient may have trouble. Now, definitely has trouble, but this patient can be, if it's only the descending aorta, in other words, a type B dissection or a type B intramural hematoma, they can treat this with a TEVAR. But if the ascending aorta is involved, then certainly you have to. And there's another example of that same patient. You understand the urgency and the severity of this problem. Spontaneous contrast there in the descending aorta. So certainly this patient has got very, very poor peripheral pulses, poor femoral artery, and even going onto the heart-lung machine will not be a good idea to use femoral bypass, because if you now retrograde bypass up that descending aorta, you may just increase the dissection into the head vessels, because certainly it's not going to go into the true lumen. Now, these patients all are, you understand that they are extremely vulnerable and extremely hemodynamically insignificant. More, I am going to move on from this one. Aortic transection. Now, this is often an interesting one, because this is a 34-year-old female in a road traffic accident. The patient came off a motorbike, I think, I remember vividly, and there's huge hemodynamic instability. But now a transection is where the full wall of the aorta has been, with an acceleration, deceleration, almost like a tear of that descending aorta. And these patients don't usually reach the hospital. They die on site, because if your aorta is ruptured, transected, then you die. But this one was very lucky. If they reach the hospital and you can get them onto the heart-lung machine, then this is a good one to to proceed or to do in the interventional radiology lab, because this is the true lumen there, and you see systole, and while outside is the whole wall of the aorta has been ruptured. We can do that then in the long axis view. Rotate your transducer to 90 degrees, and then look at this, where I'm pulling back, and I see the descending aorta from the bottom, and pull back towards the head vessels. There is the transection, and there's even fluid outside. A big, thick wall of the aorta, transmural hematoma, intramural hematoma with fluid outside. So this is certainly a very, very urgent transection of the full wall of the aorta. These patients are lucky when they make it. It can be iatrogenic. The specific patient came off the heart-lung machine, was a patient for CABG, post-coronary grafts. Then as the surgeon has cross-clamped the ascending aorta, and lo and behold, the patient's stable. Come off bypass, and I see this. And I say, well, this is exactly where your aortic cannula of the surgeon was inserted. So there is an intimal flap. It is iatrogenic. It's been created by a surgical, either a cross-clamp or where your aortic cannula has been placed. During systole, the head of the patient is on the right side of the screen. The ascending aorta flows from left to right, and there is no question that there is an iatrogenic intimal flap. We can have penetrating atherosclerotic ulcers. I see my time is almost up, Simon. You have to interrupt me. I can go on for another 6 hours, but I would hate to do that to you. But
you're welcome to go a bit over. So
tell me how long I've got. What shall we do? 5 minutes, 10 minutes, or you tell me when there's another 2 minutes left, and I'll just stop after that.
That sounds good.
Okay. So there's a penetrating atherosclerotic ulcer, and this is certainly there. We appreciate that this is the descending aorta, and these are patients with cholesterol, high levels of cholesterol, and it can create these ulcers, very, very clearly defined then in the descending aorta. I'm going a bit faster. That is, let me just get to the next slide. So this is a nice example of that in the descending aorta. Bicuspid aortic valve, important that this is a patient with bicuspid. Remember I said that it's different from Marfan's patients. This bicuspid can often go with a patient. These patients go in a very high percentage of patients have coarctation. And often a patient comes for his coarctation repair as a young child, but they preserve the bicuspid aortic valve because it's still functional. But if you've got a bicuspid valve, it can degenerate much quicker. And in a young patient, if you have a 40-year-old on the table for aortic valve replacement, 9 out of 10 times I would put my money on it, that it's a patient with a bicuspid aortic valve because they wear out much quicker. Okay, so this specific, as I withdraw the transducer that's the descending aorta. I withdraw it and I follow it, and you see the narrowing of that aorta. So this specific patient, there is a jet coming. This was a older patient with a coarctation which wasn't picked up until they pick up hypertension in the upper body of this patient. And then there is a jet coming through the very, very narrow, and again, the narrow part of the descending aorta with this just another example, and another example of where very high flow velocity with a high pressure proximal to that occlusion and a lower pressure distal. And when you put you put Doppler on, remember that we are not with Doppler, we want to be parallel to flow. In this case, we're at an angle, so it doesn't give you an exact number or a gradient. But again, we see high flow velocities of 250 centimeter per second of flow velocity across that high velocity jet. But then this typical diastolic tail. Systole, there's a gradient, but during diastole, there's a tail. There's not a clear systolic and diastolic time. So diastolic tail. And if you see that, that is a nice spot exam question. What is this image? And it's an image of a patient with a coarctation or an occlusion of the descending aorta. This specific young patient was 12 years old, I recall, and there was a very, very small there. You see a thread of descending aorta, and then afterwards the surgeon has done an interposition graft on that descending aorta. Another example of what can go wrong, the ascending aorta, we did say no vessels come off the ascending aorta unless you've got this sort of like hemitruncus almost. One valve with, and there's a big classification for this. I'm not going to simplify it or talk about congenital now, but on the one side, the ascending aorta are receiving blood from the one valve, and then the pulmonary artery are also coming off that same ascending aorta, and this is one of the hemitruncus categories of truncus arteriosus. This is a supravalvular stenosis, and I would urge you to first look at the valve, and just looking at that valve, that picture, during systole, we appreciate that doming of this patient has got a bicuspid valve, and that's typical for a doming. This is the anterior cusp and the posterior cusp, or we can talk about a coronary cusp and a non-coronary cusp, because where do the coronary arteries come off? It is there are big variations of where they come off, and they can all come off one cusp, or they can come off two different cusps. But in this specific case, they come off the coronary artery cusp or the posterior cusp, and this is a bicuspid valve. But then the ascending aorta has got an occlusion, a stenosis there. And this patient came for an ascending aorta replacement because of that ascending stenosis. Now, I'm very close to the end. There's atheroma in the descending aorta, and there's, just for your knowledge, there's a grading, the CATS classification of atheroma, and it's, as usual, it's normal, mild, moderate, severe, and how, they are mobile or not. And this is in the short axis and in the long axis. And these atheroma is important to keep in mind when you, for instance, do instrumentation of the descending aorta. For instance, they put a wire up to do a TAVR valve, and this is often a reason why you can't do a percutaneous or transfemoral aortic valve replacement. And often they have to do either go from the arch, go from the innominate artery, or go transapical. And there are many variations, and interventional cardiologists and interventional surgeons will get involved in the decision making around that. Same as you put in a intra-aortic balloon pump, you'll be very careful to put a wire up here and put a balloon pump and dislodge this, because you dislodge an atheroma like this, it'll go to your mesenteric arteries, and then next moment you've got a ischemic gut, and you sit with a patient with an acute abdomen. So a big problem with 3D, we can appreciate the nice irregular surface of that descending aorta. That brings me, I think, almost to the end of this discussion. Let's see what is next. I just, for the South Africans in the audience, they will appreciate this one. 43-year-old male from Mossel Bay. It's down the Garden Route for the people who have been there. It is a beautiful part of the country, but people sometimes get violent on a Friday night. And this man was stabbed by his best friend or his brother or somebody 18 months earlier. He had hemoptysis over the previous 3 weeks, then 18 months on, because as happens, the emergency room is extremely busy on a Friday night. The guy came in with a sort of a knife wound. They sew up the knife wound, and didn't think anything, and the guy was discharged the next day. 18 months later, there was an erosion. And by the way, he was coughing up blood, 3 liters that specific day. And then they took an X-ray because they thought he had TB, because we're in a low and middle income country and TB is rife in our country. Okay, so then on the X-ray, they saw this. And then the history came back that he had that stab wound. And this is just on a CT. We appreciate the the CT with the arch and where that knife went in, certainly in there and there. And then the patient came for a repair of that arch. And this was very high up, a pseudo-aneurysm of the aorta with true lumen where the pulsatility is, and the false lumen, almost like an aneurysm with flow. If this thing pops, it was only the suprasternal notch, the mediastinum, that kept that intact, because otherwise, if it was above or below, it would have popped and this patient would have had. And there on echo, again, the knife, very obviously, echogenic shadowing is not a good part of our echo. You don't see this, but it shows us this very echogenic part and the reflecting from the knife. And this was the blade came out, and this was the organized almost thrombus that came from that. I'm going to stop there, Samson, and I say thank you for this opportunity that I could speak here. I'm sorry that it went on a little bit. I tried to show a spectrum, not only of operations or of echoes, but a little bit of what can go wrong with a valve. And I say education is not the filling of a bucket, but the lighting of a fire. And I think everyone who is logged on here, I'm very happy to answer questions, but these are all people who are keen, and certainly